Right, so good afternoon all. Thank you for joining us on this lunchtime. So really delighted to have back with us Dr. Pawan Randev. So he's going to be delivering his third session on cancer education. For those of you who don't know, my name is Dr. Adam Mullis. I'm a GP here in Leicester, one of the clinical leads for the LLR Training Hub. Like I said, it's really great to see so many of you join us today. I can recognize a lot of the names who've come for the previous two sessions, which is really good. So just a couple of housekeeping rules. Please do mute your microphones and switch off your cameras when Pawan is talking. But of course, we want the sessions to be interactive as possible. So please pop them your kind of questions, comments in the chat. And then at the end, we'll be able to kind of go for any questions, any cases, anything else that you want to raise. We will be recording today's session as well. So it'll come automatically to those of you who registered. And we'll be obviously be sending out the slides and any associated material. So without further ado, I will now hand over to Pawan.
Thank you very much, Adam. And I'll just run through the first few slides, which is introducing myself yet again. I'm going to do this fairly quickly because I know that most of you have been on the call before. So I'm a retired partner from Mission Medical Unit, passionate about GP training and education, and specifically about cancer. And my role at the moment is that I am one of the East Midlands primary care cancer leads in the Cancer Alliance. I did have my email address on the very first slide, and you'll be getting a copy of all of these slides. And if anyone does want to follow up anything in this talk or previous talks, please connect with me. Today, we're in the third of the 3 webinar series, and we're going to be talking about understanding cancer diagnostic tests in primary care. This builds on our first 2 sessions around cancer in primary care and the update on cancer screening programs. Now, when it comes to thinking about cancer diagnostic tests, I'm going to run through a few elements, and an hour unfortunately isn't quite enough time to go through absolutely everything. I'm going to pick out some things that are important because of the nature of the condition of the cancer that we're testing for, other things that are important because we commonly request them or get those results, and they might help in interpretation. So without further ado, let's make a start and start looking at what we're doing when we think about cancer tests. And what we're doing is we're using a test either to rule in or to rule out a diagnosis. And I'll give some examples of that. However, remember that every test that we do does have a false negative rate, so you can be reassured falsely, and it also has a false positive rate, so that the test comes out positive, but the patient doesn't actually have that condition. And the posh way of expressing that is in terms of sensitivity of a test and specificity of a test. And one example is that when you think about first chest x-rays, up to a quarter of first chest x-rays can miss an eventual cancer diagnosis. So when you're looking at it from the lens of lung cancers actually being diagnosed, and you look back along the journey of those patients, up to a quarter of those patients have had a chest x-ray along their patient journey where something was seen and could have been interpreted as being cancer earlier than it really was. However, when we think about our patient population in general practice, a negative chest x-ray in a patient whose symptoms are getting better or have resolved actually does mean a low risk of cancer. So we can use that way of looking at things to reassure us and our patients. And of course, if symptoms aren't getting better, we move things on. So that's something that's important to remember, that our population that we look at in primary care is a very different population to secondary care, where patients have already been filtered and have been referred because they have symptoms. Okay. Another example is the way that we use fit tests. And we know that if a patient comes back with a fit test of greater than 10 micrograms, we refer in. But where the fit test comes back as being less than 10 and the patient continues to have symptoms, we safety net and repeat test, or we refer because we are worried. And the final point on this slide is about something called Jess's rule, and most of us have heard of this. But the reason why I'm highlighting it today is that this appears specifically in the cancer plan, which was published 3 weeks ago. And within the cancer plan, it talks about reflecting, reviewing, and rethinking if a patient presents for the third time with the same symptoms or worries. And that to us may mean discussion with a colleague or use of decision support tools like the cancer maps, or even an advice and guidance request if you're able to get it rapidly from that speciality. Now, there is an academic basis to what I'm talking about here. And with all the slides and the PDFs that you get, where you see boxes like this, you can just click on the box and it will take you through to the web page that has got this. So this is an editorial from the British Journal of General Practice looking at that very point about how you interpret negative tests when you're thinking about cancer risk. And in the right-hand box, I've tried to highlight what I think is the key element here, that you have, when you do a test, you have a risk, and the posh name is pre-test probability of cancer. And you also have a post-test probability. And so the way that we think about tests has to be within that kind of context. And this applies to any test that we do. And the example in the box on the right is around unexplained hemoptysis. So in NICE guidance, if you have unexplained hemoptysis, that is a straight to 2-week wait or urgent suspected cancer pathway referral. And you don't need to wait for a chest x-ray there. But then the problem is that you don't see hemoptysis as often as we see a number of other lesser differentiated issues that could be part of an emerging lung cancer process. And so I'm going to come back to that in a few minutes' time, because this is what underpins what we're trying to do whilst working in primary care. And to start off with, I'm going to highlight the essence of the cancer maps. And we've mentioned these before. And the cancer maps is a locally produced visual representation of all of the NICE guidance around suspected cancer, developed by a GP in Loughborough, Ben Noble. It works on putting in age, sex, and symptoms on the right-hand side in that green panel. And then you get bits of the cancer maps lighting up with either a hit or a near miss. If you want to know more, just click on this image and it'll take you through to the maps, and it's a very helpful tutorial. Now, when we think about lung cancer, and I've taken this screenshot from the lung cancer part of the map, and I mentioned the hemoptysis. And if you look towards the bottom, you can see hemoptysis over the age of 40, straight 2-week wait referral. But then when you go higher up and you go to the top right, if you have someone in front of you who's older than 40 with no smoking history, but they have more than 2 of weight loss, appetite loss, shortness of breath, cough, fatigue, or chest pain, then actually that patient, we should be thinking about a 2-week wait, a chest x-ray within 2 weeks. And if you have somebody who's a smoker or an ex-smoker or has asbestos exposure, you only need one of those items. So we're starting to see that, hold on, the chest x-ray it's been around forever for us. And sometimes we forget how important a tool it is when we're evaluating symptoms and when we're trying to work out whether to reassure the patient, safety net the patient, or refer them. So I'm just going to stick with the cancer maps, but this time I'm going to look at a different scenario, and I'm going to look at the role of the CA125. And if you look towards the right-hand side, lower part of the box, those are the symptoms that typically should trigger us to consider possible ovarian cancer. And you can see IBS symptoms, bloating, abdominal pain, bowel habit changes, weight loss. And if you have, as you work through those symptoms, more than one of those occurring in a woman, especially over the age of 50, that should raise suspicions. And the red arrow is showing you that if you order a CA125, which is what the NICE guidance suggests, there is a false negative rate of almost a quarter. If you have an ultrasound scan, the false negative rate is only 10.5%. So it starts to make sense to consider a woman who has those symptoms. Should I be doing a CA125 and an ultrasound test? And so we're now starting to think about combinations of investigations. And the MAPS is especially useful because where you see those amber round dots, then those tell you the false negatives of different tests. And if you click, as the red arrow shows you in the box, on the blue round information panels, then that will give you the background and risks and additional information about that cancer. So for ovarian cancer, you can see that there's a lifetime risk of 2%. There are particular issues around genetic mutations, including the BRCA genes in particular, and also in general family history. And if you want to expand your learning, then at the bottom, there's a link to the ovarian cancer early diagnosis module in Gateway C. So I'm hoping that you can see how the cancer maps will help to refine the investigations that you undertake at different stages of the symptoms being presented to you by patients. I'm now going to move on to a test that we should all be pretty familiar with now, the FIT test. And I'm going to talk about this for a couple of reasons. I think you'll realise why this matters. So the FIT test recognises specifically human haemoglobin. And importantly, it isn't influenced by other blood in stools. And that's ever so important because you can have rectal bleeding and still use the FIT test because it's testing for the presence of altered blood and not fresh blood. The advice we give to patients when we ask them to do a symptomatic FIT test and they have rectal bleeding is to try, if they're able, to sample that part of the stool that doesn't have fresh blood on it. If they're able to do that, fine. If they're not, actually we can still get a useful reading. And because it's immunochemical, you get far fewer false positives. And of course, you get the quantified result. And a positive FIT test, as we know, suggests bleeding within the GI tract. In particular, we're looking at micrograms per gram, and that when it comes to the test itself, it's quantitative so that the thresholds can be changed. And I give at the bottom of this slide, where it says Scotland, Wales and England, we use exactly the same test for bowel cancer screening. And because it's quantified, then you can change the rate. And if you look at the bottom bullet point, in England, our screening fit currently uses a cutoff of 120. The cancer plan 3 weeks ago has announced that that's going to be reduced to 80 micrograms. And we talked about this in more detail at the last webinar if you wanted to have more information about it. Therefore, the point I'm coming to is that the screening fit is different to the symptomatic fit. And Cancer Research UK has produced a very helpful flowchart that will be useful both for yourselves as a reminder, but also if you click on the image that I've put there, you'll be taken to the page and you can print this off for yourselves or for other colleagues or trainees that also order fit tests. And I'll show you in the next slide an example of why this matters. But this is a difference between the symptomatic fit that we give out in practice and the screening fit. So I use my Tom Hanks example and only chose Tom Hanks because most people have recognized him. And let's imagine that Tom Hanks is 64 years old, ready to go up and receive an Oscar. And he comes to see you. And he tells you in your surgery, look, I completed my fit test 3 months ago. It's completely fine. I've had a bit of tummy pain since then. Had a bit of a dark poo a couple of months ago. Haven't noticed any blood. Those bloody piles are playing up a bit, and every now and again there's a little bit of blood. Nothing else has changed. So what do you do? And I hope that you can get the sense here that you can't use the screening test to reassure you or Tom, that there's nothing to worry about, because the screening fit can be entirely normal. That'll only trigger if it's more than 120. But Tom has got rectal bleeding, intermittent, hasn't got any weight loss, has had this darker coloured stool. So there's enough in there for you to start thinking about doing a symptomatic fit test. But of course, in these situations, as good GPs, we're always going to take a full history. We're also going to establish if there's a family history. We're going to establish what his concerns are, and we're going to examine him. And we'll order some investigations. Now, there is something called the 4Fs, which was developed in Nottingham by one of their primary care physicians. And the 4Fs of evaluation are full blood count, ferritin, fit test, and finger. So the digital rectal examination is key. And if you do those, then brilliant. You know, you've done the full workup and you'll have enough information coming back from those diagnostic tests to help you to make a decision. Now, I've also put as one of the bullet points, should you consider repeating the fit? So if Tom has a fit test and it comes back as 8, but you're not quite happy with that, and you decide you're going to safety netting, is there value in repeating the fit test? The short answer is that we don't know, but we are undertaking a large research study in Nottingham to try and find out. What I would say is that if Tom remains symptomatic and if your level of concern is such that you think about repeating the fit test, for most of us, we think between 4 and 6 weeks after the original fit test is reasonable to repeat it. And of course, if it's greater than 10 at that time, then you've got a clear pathway to referral. But that leads on to safety netting. And I'm not going to cover safety netting specifically today, but if people are interested, I've got a separate presentation on safety netting itself. And just on that note, this morning we had some news because some of you on the call on this webinar today may have been involved in an expression of interest that we put in nationally for a safety netting pilot project around fit testing. And the great news is that the East Midlands has been chosen as a site in England to pilot this. And there are PCNs in Leicester and Leicestershire that are going to be taking part in this pilot. So very good news around safety netting. And if people want to know more, just email me. So when we are using FIT, The other thing that we need to think about is if somebody's got a fit less than 10, but they have rectal bleeding or obstructive symptoms or a palpable mass or anemia, low MCV, low ferritin, then yeah, these are all good reasons to actually refer the patient on the urgent suspected cancer pathway. And this is what NICE now tells us. So that's fit testing. The next thing I wanted to highlight was using a test that we use all the time in general practice, the full blood count. And some of you may be very aware of this and teach your trainees this, but some of us may benefit from a refresher on raised platelets as a marker for possible cancer. And we remember Lego C, Lego as in the children and adults building toy, and the C. And if you look towards the bottom bullet point, the acronym stands for lung, endometrial, gastric, esophageal, and the C stands for colorectal cancer. Now, where can we use this? If we have somebody where perhaps we think they may have a lung cancer, or they've had a persistent cough, or they're over 40 and they present with that range of symptoms, and we are wondering, then if we did a full blood count and it came back with platelets that are above the normal range, then this is one of the things that should raise suspicion. It's not a 100% marker, but I'll show you in a minute where this works. And this works even more powerfully if, once you've excluded other reasons for raised platelets, if somebody continues to have raised platelets, typically a month to 6 weeks apart, then their risks of underlying cancer actually are significantly raised. So the research, and this is a graphic taken from the research papers, on the left-hand side, on the y-axis, that's the 1 year incidence of the particular cancer in men. And this is mirrored in women, but in women, of course, you have endometrial as one of these. The key thing is when you look at the y-axis is that we are supposed to refer when somebody reaches a 3% threshold or greater. And when you look at the red bars and you go across and look at colorectal, look at the red bar there. A high platelet count, which is the red bar, greater than 400, hits that 3% mark. And if you look at lung, a high platelet level greater than 400 goes to 3.5%. So if you have someone who has elevated platelets, is a bloke, has some of the signs that we've already seen in the cancer maps or symptoms, then having raised platelets is yet another indicator to consider referral or CT chest, or certainly at the very least chest x-ray. One of the other things that the research has moved us on to realizing is that the more chest x-rays you do as a practice, the more lung cancer you will diagnose. And there's a likelihood of actually getting slightly better survival outcomes. And this is a really important paper because we are often being hammered for the numbers of tests we do, and pressure, both overt and covert, is put on us to reduce the number of investigations. I'm afraid in this situation, the evidence is completely the other way. And within this large variation that we have of use of chest x-ray, looking across England, what this has shown unequivocally that using chest x-ray for patients with symptoms actually makes a big difference. And remember that in lung cancer is one of those cancers that has a doubling time of just a few weeks. So some of the specialists believe that if you delay the referral by 2 weeks, you can actually double the size of some of the cancer, some of the non-small cell cancers in particular. So time does matter with chest x-rays and lung cancer. So one of the elements that actually, when we're thinking about time, that causes a delay is patients making an appointment to see us and getting into the system and recognizing themselves that a persisting cough matters as a symptom. And when we think about lung cancer, this is a graphic that I've borrowed from Manchester. And this graphic illustrates a few very important things. And most of these we will be aware of, but I just wanted to bring them to front of mind. And this summarizes the key elements of lung cancer. But one other important element that I've highlighted with the red arrow is don't forget never smokers. And if you think about never smokers lung cancer as a separate kind of cancer, that's the 8th commonest UK cause of cancer-related death. So just because somebody hasn't smoked doesn't mean they can't get cancer. If you've got lungs, you can get cancer. So that's something that I think I can't repeat often enough. What I'm now going to talk you through is what would happen if you removed trying to get a GP appointment out of the mix. And what we did in Colville, so this is a local LLR pilot, is that we had a project where we looked at self-requested chest x-rays. So within part of Colville, practices took part where patients in the community, so not people who'd presented, but just for patients over the age of 40, were sent a text saying that if you have symptoms or if you develop symptoms, then this is the way of getting a chest x-ray without having to book in with a doctor. And you ring the number, speak to a radiographer who takes you through a checklist, gives you an appointment for the chest x-ray, you go up and have it within a day or two, gets reported, and that's all done. And what happened? So the outcomes of this pilot were that over the space of 9 months to a year, we did over 300 chest x-rays based on symptoms. And these were people who were symptomatic and based on the triage protocol would actually, from a best practice perspective, have been sent up for chest x-rays anyway. But of those, we've had 3 people, 2 who had confirmed lung cancers, 1 with a suspected lung cancer, which they are monitoring. And in addition, there were many people who had other significant incidental findings, which led to them having changes to their treatment. And Michael, who took part in this, actually shared his experience. And Michael, being a bloke and having a Land Rover to do up, really didn't have time to go to the doctors and had been coughing for 7 weeks, happened to receive the text message, rang the helpline, was diagnosed and is on treatment. And having that permission for him and for many, many people, as you've seen, actually meant that they took action based on their symptoms. And within the cancer plan, self-requested chest x-rays has been highlighted as something that's worth exploring in different areas in the country. And we are hoping to be able to expand this service. And Ben Noble and I are in discussions with colleagues around Leicestershire. So that's self-requested chest x-rays, that's fit testing and platelets. Let's move on now to think about CA CA125. And this is a test that we're requesting quite a lot. The numbers of CA125 requests has been going up significantly over the last few years. And what I wanted to highlight to you is a study and a set of findings that actually make a difference to how we interpret it. And there are two elements to it, and I'm going to deal with the first now. So the CA125 has been around a while. Has it been evaluated in primary care? Well, not until this particular bit of research. And this study showed for the first time that if you have an abnormal CA125, it doesn't only link to ovarian cancer. Actually, in the 1,000 women in this study who had raised CA125, over 350 had ovarian cancer, but 380 had other types of cancer, which turns around the way that we interpret CA125. So it's not necessarily a specific marker just for ovarian cancer. It can reflect other kinds of cancers, including pancreatic, bowel, or lung. And part of the reason for that is that CA125 is secreted by the lining of the abdomen. And so those cells, those peritoneal cells, can be stimulated by other forms of cancer. And what that means in practice, and this is the paper itself that summarizes this, is that if you have a woman who has a raised CA125 and you rightly arrange for her to have an ultrasound, and the ultrasound comes back and says, no ovarian cancer found, or the ovaries are both normal, what should you do? And the answer is actually in women who are over 50, and this is where the data is strongest, you should revisit the history and examination, consider whether that woman should have a chest x-ray, whether you should do a fit test, whether further abdominal examination, perhaps with an ultrasound or a CT. You should start to think about maybe thinking of it as a patient who's almost ready to go down the non-site specific route. Should I do the filter function tests for the NSS? Because that's really that set of things. And for those of us that want a bit more detail, this is a table from that paper. And if you look in the far right, that's the set of women that this is the table of the women who had raised CA125 and cancers other than ovarian. So we had 49 women who had lung cancer, for example, and 46 women who turn out to have pancreatic cancer. You can work through the table and see what it all means. But if you look at the lower GI, there were 58 women, 23%, that had a lower GI cancer and a raised CA125. So I hope you can see that this is potentially a practice altering piece of information for you, because it now means that those women who perhaps we would have safety netted or monitored or repeated their CA125, this is actually giving you the basis of a different approach for those women. Now, the second big change that's happening is NICE is looking at the age cutoff for CA125. At the moment, we use CA125 over 35 as being our cutoff for worry about potential ovarian cancer. The research now shows that actually CA125 changes with age in terms of cancer risk. So a CA125 of 35 when you're 70 is far more predictive of ovarian cancer than a CA125 of 40 when you are 41. And as a result, NICE has just completed their evidence gathering for changing the threshold so that they're different with different ages. I'm sorry, but I can't tell you what NICE's eventual recommendation is going to be because this closed at the end of January. And what it does mean is please look out for this because when it does come through, then that is going to alter the way that we see CA125 on an age cancer risk profile. And hopefully our laboratory results, when they come back to us, will reflect that. And there may be some information with it, but that's something that we will design for everyone once we know what the NICE change is going to be. The next thing I'm going to move on to is PSA testing. And PSA testing is something that, well, I think it's something that for me, as I've got older in practice, I seem to see in every surgery 2 or 3 men, often retired accountants with lots of time on their hands and a feeling that they understand data, coming to me and asking for a PSA. And this can become quite a challenging consultation. You can adopt the, well, you're over 50, you have a human right to have a PSA route, but that means you'll do an awful lot of PSA testing. So I'm going to show you in a minute where NICE is on this, but we have a draft guidance that is currently going through our authentication process. And I had hoped that it would be ready for today, but for various reasons, I can't share with you the full protocol. But if you are signed up to these webinars, what I can do is ask the Training Hub to send you a link to this document as soon as it's been fully authorized, which should be within the next 2 or 3 weeks. And this has been put together by Ben, who's now become almost a national authority on primary care and the PSA test. But I took out from his document one thing that often vexes us as GPs, and that is the value of doing a digital rectal examination. And suffice it to say that this is an often debated issue, and it's debated both within ourselves in primary care, but also by urologists. And what we know is that actually, if a urologist is to do it, and these are consultant urologists, then there's a 60% sensitivity and a 67% specificity. So actually, it's not brilliant. And in primary care, it's much lower. And so the studies and the research suggests that if you have a man who has a PSA of less than 4, between the ages of 50 and 70, and they come to see us as GPs, you need to examine about 11,500 of those sorts of men to detect one cancer. So the bottom line then is that if you've decided to do a PSA and the man has a PSA less than 4, then actually performing a digital rectal examination is very unlikely to pick up a cancer. Now, that matters because one of the things, especially in different ethnic communities, one of the things that really puts men off is the worry of having a rectal examination. And because we as blokes are the weaker sex when it comes to thinking about this kind of thing, little things like that do put us off. And when you look at black men in particular who are at higher risk of developing prostate cancer, culturally having a DRE or having the folklore from other men about how painful the DRE might be actually deters men, which then means that potentially if they come to see you, they may well end up at a later stage of diagnosis. So For those men where we've done the PSA, actually a DRE is not going to add anything. And when you look at our guidance in LLR, the necessity of performing a DRE is actually reduced. Interestingly, Ben and I have had conversations about rectal examination, and one of the things that was brought up to us by actually a GP as part of this was, is there a difference between male GPs and female GPs in terms of sensitivity on the basic grounds that men overall might have longer fingers or that sort of. And we don't know that that's ever been broken down fully. And I guess that if somebody's got time on their hands and they perhaps bought one of the testing models, then it may be a Christmas BMJ paper if anyone's interested. Personally, yeah, less so. I think I'll let somebody else take the glory for that and then be featured in the Daily Mail. Let's move on to the prostate cancer screening ideas. And I mentioned a second ago that the National Screening Committee are looking to see what the screening recommendation is going to be. And initially, in their draft recommendation, they'd suggested a targeted prostate screening program for men with BRCA, but it's not recommended for population screening and controversially not recommended for targeted screening for black men or with men with a family history. So the consultation for this document actually completed on the 20th of February. So there's going to be a period of 2 or 3 months where all of the feedback is going to be looked at, and the screening committee will issue guidance within the next 3 months. And once they do, this will be all over the place. It'll be in Pulse, it'll be in GP Online. We will be broadcasting it far and wide. And I will bet you that your patients will hear about it as well. So keep an eye open for this, because your patients certainly will see this and will be coming to you once this has been confirmed and put out there. There is lots of research going on looking at whether we can use MRI plus PSA, or actually developing more accurate tests than PSA itself. So eyes open for that. The next thing I wanted to look at was a condition that we don't see a great deal of in general practice, but this is the cancer that actually takes the longest time frame between initial presentation to us with symptoms and eventual cancer diagnosis, and it's multiple myeloma. And multiple myeloma, looking at the NICE guidance, we should be thinking about this for people aged 60 and over with persisting bone pain. And this cohort of men and women, if you've got back pain, actually, that's most clinics, most surgeries will have people with known OA, with back pain, and so on. So it's difficult to bring this out in terms of which patients we're going to undertake the investigations. And NICE is clear about the investigations that they want to offer. This is in the over 60s, but they also say, do you know what? Think about the under 60s as well. And this is really important, because for whatever reason, we seem to be getting more people under the age of 60 coming through this. And this is somehow reflected in increasing numbers of many cancers in younger patients. And another example is bowel cancer in the under 50s is increasing fast. So what tests should we consider? And I found that Myeloma UK has actually got probably one of the clearest explanations of what we do and why. And they talk about the CRAB criteria for myeloma. And so they're talking about raised calcium, renal impairment, anemia, and bone pain as being one of the major symptoms for patients who might have this. But also remember that fatigue, weight loss, recurrent infections, and even shortness of breath. So if you do start to think along those lines, what should you request? And the key thing, as well as the full blood count, calcium, and renal function, the key thing is serum protein electrophoresis. And at the same time, requesting something called the serum free light chain. Most of us in medical school were taught about the urine Bence-Jones protein, the BJP. And for decades, we've had that as one of the key markers. Serum free light chains is much better as a marker. So some of us are aware of it and using this all the time. For others, this might be new, but this is something that you can request if you want to exclude, in other words, rule out myeloma as one of the causes of those relatively common sets of symptoms. Now, I've deliberately kept today's webinar a little shorter than the previous ones because I'm conscious that there were questions and we ran over time with them. But I just wanted to remind you and ask for your help in completing a feedback form, both for this webinar, but if you've been on any of the previous webinars, it is honestly very short and it's just asking, what 3 things have you learned that you didn't know before from the webinars? Then what 3 things you're going to do differently? And then finally, just asking how you found the webinars and whether there's anything that was done well or could be better and that you'd like to feedback to me. So I'm going to stop sharing there. And I think, Adam, it'd be helpful if you could perhaps let me know if there were any questions and we can open this out to general discussion. I'm very happy to take questions on things that we've covered today, or if there are any things that come up from the previous webinars, we can talk about those as well, because we've got a good 10, 12 minutes.
Thank you, Pawan. And yes, exactly that. We've got a good 10, 12 minutes now to go through the queries. So please do pop them in your chat or raise your hands. But I can see there's quite several questions already which have come up. So Pawan, we'll go through them in turn. I mean, David's asked about with the 4Fs, can one use CRP rather than ESR, which we don't have easy access to in Leicester?
You can use CRP as well. And in the guidance, for some reason, NICE defers generally to ESR, but I think it's because it's nationally more widely available. CRP is good, but it's the same as ESR. It's a relatively soft marker, I'm afraid. And with the 4Fs, remember it's full blood count, ferritin, finger, and fit. So that's the profile that they've piloted, and we have the strongest data from Nottingham Primary Care to support.
Just on that note, plasma viscosity, does that have PV? Does that have any
It's
role to play, Pawan?
they're all markers of,
Yeah.
of inflammation. And in fact, one of the things to remember is that raised platelets are also one of the non-specific markers of inflammation. So when you're thinking about the Lego C, if somebody's had a bad chest infection, that's a very good reason for having a set of raised platelets. And you could just repeat the test in 4 to 6 weeks and it'll have come down to normal.
Definitely. So David's asked just on the note of platelets, actually. So David's asked a question about raised platelets using AI. Very topical. I know, pardon, we were just talking about that before. But so AI was implying that a level of platelets over 460 is more significant than a borderline ones, which are just over 400. David's just put a comment. Perhaps maybe a good registrar quick project search for borderline platelets. Any positive outcomes in terms of cancer detection? In those kind of borderline ranges.
The answer is yes, and there's a particular paper where they have actually looked at that. And the reason they looked at it is because internationally we all have slightly different cutoffs for raised platelets. And what has been found is that there's a gradation. and that in fact, when you look at cancer risk, even having platelets that are high normal can actually be part of that indicator. The evidence isn't hard enough to put into guidelines yet, but the signal's certainly there. And so in terms of a QI project, one of the ways of looking at that is either by
Mm,
looking at confirmed cancers and looking at
mm,
your confirmed Lego C cancers. That's one way of doing it. The other way of looking at it, which can be a little more creative in a way, is to look at those patients referred on the suspected cancer pathways who had that, because the numbers of patients who have had actually confirmed cancers will be a much
mm,
smaller subset of those that have been referred on the pathways. And so you can look at both.
mm. Thank you, Ron. Asper's asked, how can we take part in the FIT safety netting pilot?
Um, I'm afraid, Asma, that the expression of interest already went in with those PCNs that are already that already committed, who felt that they had capacity. If you are in if you are interested in knowing more about it, please just drop me an email, because the pilot is really looking at one particular approach of safety netting. And in reality, as part of best medical practice, we should be safety netting patients who we have requested a fit on anyway. And I've got a presentation that I'm very happy to run through with anyone that wants to run up. And it also becomes an excellent QI activity for appraisal and the thing that you keep in your back pocket for CQC, because when CQC are asking, how do you have appropriate safety netting protocols, then if you're able to generate this, and also within the process, we've got a built-in audit. So you can say, we have this thing that
Mm,
we have this safety netting process. This is the audit that we do every 6 months of return. It's all sorted for anyone that wants to take part in it. And I would say, Asthma, from memory, I think Asthma's in one of the city PCNs. Um, and if you are, then you've it's what we've found is that it's those patients who are either slightly younger, black or Asian, um, with lower health literacy and in a more deprived population. Those are the ones, not surprisingly, that are far less likely to return their fit tests. And so if you are in the inner city and this is something you've either noticed already or worry could be an issue, then I can help. And if you want, one of the other offers is that if you wanted to have short videos in Urdu, in Gujarati, and in English, so 2-minute videos that you can send to patients that show them how to do the fit test, I've already created those. So anyone that wants to do QI with that, and as most GPs, we always prefer subcontracting to our trainees. But if you have a trainee that's keen on doing this, or in an ideal world, perhaps 2 or 3 trainees in a PCN running it for the PCN, if you wanted to scale anything like that, just get in touch.
Fantastic, Pawan. So, a couple more questions there. So,
Yep.
Lucy's asked, patient has a private fit test via online company. Result is 40, so registered but asymptomatic, brings result to the GP on the NHS. So, how do you approach this?
Okay. The way that I would start to look at it is review all of the symptoms. I would then move into the 4Fs, ensure that they don't have an abdominal mass. I would also do the rectal examination, etc. I personally would probably repeat the fit test. The reason being that with a private lab, sometimes you can ask the private lab for proof of QA. When I don't know if you remember the old days, Adam, when we had to send the fit test that we order off to Nottingham. And,
Yes, yeah, I do remember that.
right.
Yeah.
So when we changed it to being offered through Leicester and got a far better service where we get turned around within a day or two, when we changed it, the lab had to go through this massive quality assessment process. And private labs may or may not have to. So you've got to know the quality assessment of the test. Also, there are a number of different fit tests that you can use. So the certainty from a medico-legal perspective, if you wanted to be sure that that fit test of 40 is true, then I would probably repeat it. Because the other thing is that then that fit test is in the system, so that if you do refer the patient, that then everything is going to flow more smoothly in terms of triage once they hit secondary care.
Mm, interesting.
But
So,
full blood
uh,
count, ferritin,
yeah,
etc., for sure. And that also,
yeah,
by the way, Adam, takes me back to what we talked about in webinar 2 about
mm,
bowel cancer screening. And the
mm,
tip that I gave people around when you get your screening test back, contact the hub and ask them for your number. And if it's
mm,
over 100, I myself, and of course, I can only say what I would do, I would want to know what my full blood count, ferritin, and so on was. So,
mm.
there's something about that kind of knowledge. And
So,
you notice that, in that question, the private companies do tell you your number.
yes, yeah, I've had that for some patients. Well, they
Yeah,
have to give you the number. Yeah, very true. So, Pound, there's just a couple of questions around CA125. I'll just kind of
yep,
summarize
sure.
them. So, one is about when a raise CA125, what the level is, what the cutoff.
Yep,
And David's asked CA125, obviously because of it, how non-specific it can
yeah.
be, can it be used in men to screen for things like pancreatic, lung, and GI cancers? And then Hina's asked for women with a repeat CA125 that comes back normal with a normal
Yeah.
ultrasound, what further investigations would you suggest?
Okay. So the current cutoff is 35 international units, and it applies at 35 regardless of age. That is the threshold that NICE is looking at. So that will change once NICE decides on the recommendation. The second point, I think from David, and you know what? I've got a memory of a sieve today. Can you just briefly remind me of Dave? Oh,
Yes,
David's
not to
question
worry.
around men. Yeah,
Yes,
that's
that's it.
right.
Yeah,
Now,
yeah, yeah.
David, that's an excellent question, one that I have asked myself. And when I've asked the researchers, they say that the evidence isn't there. My feeling has always been the evidence isn't there, but it's only because we haven't been looking. And the study that I would love to do is to look at men with pancreatic cancer and see what their CA125 is. And this is where the evidence base has to catch up with practice. So I think that this is something that we will be looking at, but at the moment, the research focused hasn't quite reached there yet. And also the labs will get pretty cross if we start doing that because I don't know how their computers are set up, but I've got a feeling if you could send it in for a man, then you'll have a discussion at the very least. You could try blaming me for it, but it may not work. So the final question, I think, was around raised CA125, normal ultrasound scan. What next? So I think this is a nuanced answer here because in younger women, it is said that fibroids can raise CA125, and you can imagine how
Mm,
a grossly enlarged uterus and so on may irritate the peritoneal lining. I think I would be guided. I think that for me would merit review of that patient. So starting from the beginning. So remember that Jess's rule that I would go back and review the history and examination, and then I would start to think, do I need to do a chest x-ray? Should I be thinking of ordering a fit test? Should I be thinking of an ultrasound scan of the abdomen, thinking about pancreas? Um, should I be repeating or expanding, doing the full blood count, the ESR? I would review the patient afresh, but say we have a signal of something going on. If all those things are normal, then they're normal. But if having done them all, and the quickest way of doing them, to my mind, would be to treat that patient as an NSS patient, and therefore you'd order the filter test bundle as well as the chest x-ray, and that means that you don't miss anything out. then review the patient in the light of those results.
Interesting. So, sorry, I'm very mindful of the time, but if people are
Yeah.
okay, there's just one or two questions that we want to just finish off with. Aspen's made a comment just about the anatomy of the finger length in females.
Oh, right.
I've I've come I've got I've still got a pride. I've got this prostate box. I remember had it for
Right.
years, and it's the one that I've used it with some of my trainees, and yeah.
Yeah.
Anyway, the next comment was from Salma. Apologies, I know this was not discussed, but would you also suggest doing a myeloma screen on patients with a raised globulin, and what level of globulin would be of concern?
Very good question about the globulin, and I don't think I can give an absolute value of raised globulin because if you think of, well, the way I see it is that we see people at all stages of myeloma at an early developing stage as well as later stages. My instinct would be to say that if you have concern, if your patient's symptoms fit, I would consider doing an serum electrophoresis. So do an IEP. And to be honest, if you're going to request an IEP, you might as well ask for serum light chains as well.
Yeah, yeah,
And I would be good about because myeloma is the reason why it's difficult to pick up in general practice is because it's such a vague set of presentation symptoms, and they're so common in the over 60s age group that, to my mind, if you use the myeloma screen as a rule out test, then for me, it's one less grey hair for yourself, that you've ruled
yeah.
it out and that you can then carry on managing the patient, knowing that one of the serious underlying conditions, well, we don't have any evidence for it being that. So that's perhaps
I,
the
yeah.
pragmatic approach I would take.
I agree with that, Paul, and I think I tend to do that as well because it's those vague symptoms that they present with, and at least you
Yeah,
know that look, you rule that out. But certainly the over 60s,
yeah.
it's a test that I like to use. VJ, I don't know if did you want to unmute yourself to ask your question? This is the last question, if it's easier, if you're available. If not, don't worry, I can read it out. Um, Don't worry, so I'll read it out. So it's basically a patient with chronic fresh rectal bleeding, not examined before, elderly patient. No worries, VJ, that's fine. Not examined before, elderly patient, intermittent fresh bleeding, but no new change in bowels. Digital rectal exam, small hemorrhoid. No new changes in bowel. I did not order a fit test. Is that correct? She's over 80. When is the threshold for fit? She has a diagnosis of myeloma, so CRP and platelet will be high anyway.
Okay. So one of the one of the things that I've shown before in the screening webinar, in webinar 2, is a slide which shows the incidence of bowel cancer by age. And the peak incidence of bowel cancer by age is in the 70s and over. So between 70 and 85, 86 is the maximum incidence for both men and women. For the case that you're presenting, you have somebody that has rectal bleeding. So when you think about the cancer maps, for example, and you think about NICE guidance, that would suggest you towards doing a fit test. Now, the question is then a more nuanced one that if you have somebody that has multiple comorbidities, you then have to ask, well, is this patient, if we knew that if we did get a positive fit, what would we be doing differently? And I've had this question as a variant for patients who are housebound, for example. And the general response has been actually, does the patient and their family want to know? And do I need to know so that I can then plan appropriately with the patient for their future care? So if the fit test is 100, then there's a high likelihood of there being an underlying bowel cancer or even inflammatory bowel disease, because you still can't rule that out, even at that age. So going back to the case that's been presented, the intermittent bleeding and finding a pile, I think because of the age, I would still do a fit test. And you have to, however, do the fit test, having thought through what your next steps might be. And also, I appreciate that in somebody who's got an existing myeloma, the blood test may not be as useful, but then I would go for the fit test itself because it's organ specific.
Thank you. And just last question to finish off with, David's asked, in terms of repeating raised platelets,
Yeah.
when should we do it?
So I can give you the group consensus on this. So there is no one set of evidence. However, the majority of us would go for between 4 and 8 weeks. And most of us split the difference and go for 6. The reason being that sometimes if you have raised platelets because of really nasty pneumonia, that can take a time to settle. And as you know, with pneumonia, sometimes you get localized pockets of infection which take a while to settle. And so the inflammatory response can persist. Now, when you think about what the radiographers tell us to do, which is repeat chest x-ray in usually 4 to 6 weeks, that feels like a really useful starting point. So I would be thinking around that. Now, David, within your question, there's another element as well, which is the graph that I showed you of the 3%, of the 3.5% 1-year risk of lung cancer for men with 1 raised platelet. If you do that in men who have got 2 lots of raised platelets, so 1 today and 1 in 6 weeks' time, that number goes up to over 10%. So if your platelets are raised twice within that short window, then your risks has bumped right up. And that individual, you really need to be thinking about rapid further investigation. But remember that the raised platelets, Lego C, remember all of the organ systems that we could be thinking about. If it was a bloke, at least you can put endometrial to one side, but the rest of them are still there.
Brilliant. Thank you, Pawan. So I'm just very mindful of the time, so I think I'd like to draw the session to a close. Pawan, thank you for an absolutely fantastic session, and also obviously the whole 3 series that you've done. Really do appreciate it. And thank you as well for those who've attended, for your engagement and also your questions that you put through as well. I know Pawan did put his link for there about his feedback there. The Training Hub, we do have our own separate feedback form as well, so we would appreciate if you could complete both of them. You will be automatically sent the recording of the event, and we'll ensure that you get the slides as well afterwards. But otherwise, I hope you have a good rest of the day, rest of the weekend. I look forward to seeing you next Friday for our next Training Hub event, which is on the Fit Note. So we're going to be discussing kind of work and health and work and conversations you can have with your patients. So look forward to seeing you then. Take care all.